Good morning, everybody. On behalf of IAP Pune today, me, Dr. Sushrita Deshmukh, along with Dr. Manoj Zalte, who is the president for 2025 for IAP Pune, wish to conduct this session to sensitize everybody about the recent outbreaks of GBS which we have seen in pockets of Pune, and to tell the general pediatrician how to pick it up, when to refer, what needs to be done, and what is the authority doing to curtail this outbreak. So today for this discussion we have our esteemed panel of Dr. Pramod Kulkarni, who is a pediatric infectious disease specialist, Dr. Kiran Mahankare, who is working with Kamla Nehru Hospital and who is associated with the Pune Municipal Corporation, and Dr. Sandeep Patil, who is a pediatric neurologist at Dinanath Mangeshkar Hospital. So handing over to Dr. Manoj Zalte to begin the discussion.
So good day everybody. So we start with Dr. Pramod Kulkarni sir. What is the GBS?
Good morning. Thank you, Manoj, and thank you, IAP. Guillain syndrome, GBS, as we know, is a neurological clinical syndrome complicating common infections as recently seen the Campylobacter diarrheal disease, or can follow other common respiratory infections as well. It's a clinical syndrome typically affecting young children, adolescents and adults, and preferably male. It's a clinical syndrome, it's a clinical neurological problem which develops over days, lasts over weeks and recovers over weeks to months. It usually recovers very well, but it has got its own risk due to the flaccid paralysis, which is classically known as ascending paralysis, which can occasionally lead to fatal complications like respiratory failure, and needs early recognition, early treatment for a best outcome, which is quite possible in Pune.
So Dr. Kiran, now going ahead, what exactly happened in Pune, and were there cases which we found in Pune clustered around a particular area, or did we get a widespread spread of these cases?
GPS occurs sporadically throughout the year. The cases are few, but around second week of January, the GBS cases increased, and mostly these were admitted in Dinanath Mangeshkar, Navle Hospital and Varieties Hospital. Due to this, the alarm was ring. They contacted the PMC officials for this increased number of cases. Other than the increased number of cases, the PMC officials took note of this. They found out where from these the patients are particularly from which area. They located the area. They did the house-to-house survey of this area. From this survey, they found out that there was a common source of infection, waterborne infection to these patients. So they found out this source, and this area was located from the Sihagarh Road, Dahiri, Kirketwadi and Nanded City area.
Okay, so now what is the current situation to date of the number of cases here?
Current situations, there are up to date there are 136 cases. 95 patients have been discharged. 32 patients are admitted. Of it, 13 patients are on ventilator, 8 are on O2, and the other 11 patients are in the ward.
Okay, so quite a few have shown good recovery.
Yeah, and there are no new cases since last 6 days.
No. And how is the local authority now responding to this outbreak?
Local authority have, as this occurred, just because of that source, impure source of water, they have decided to, as they think that this might be due to drainage of some poultry, or as in that particular source of water, they have decided to curtail all these poultry farms or poultry cutting shops, and they have decided not contamination of water in this.
Okay. Now, Dr. Pramod Kulkarni sir, the most dilemma is how to suspect, when to suspect GBS. Can enlighten with pediatrician also, and how to counsel parents also.
Yes, again, the first point to suspect Guillain syndrome, as we have already said, it is the weakness of muscles and movement. So the common presentation in children and adults are difficulty in gait and posture, that is inability or difficulty to stand and walk properly, which develops over few hours. Then second is inability to get up or walk. It's an advanced stage. And initially, usually it is preceded by some sensory symptoms like pain in your legs, back of your legs or lower back, tingling numbness sensation in your toes or fingers are the early manifestation. Typically, if worsening over few hours and which is not accompanied by any other symptom, we have to suspect Guillain-Barré syndrome and take a due early note of it for keen monitoring over next few hours, which is very important.
Yeah, and this applies not only this anytime, not only in epidemic also. Anytime this such thing.
These are the early clinical pointers of a possible Guillain-Barré syndrome, which is acutely progressive, flaccid or hypotonic weakness.
Yeah, and we are told that flaccid paralysis. Any case, we have to report and to the authorities, PMC, like something like that. So how it typically behaves, GBS in clinical course?
Usually, as we have said, the male and boys or young adults are being affected. Following the initial infection, which can be a diarrheal disease or any respiratory infection, usually within 2 to 4 weeks of this infection, which wanes away, and you suddenly get the neurological symptoms like flaccid weakness in form of difficulty in walking, standing, in a progressing over hours, usually over hours, ascending paralysis. That's the typical, but it can be different way also. Sometimes you can get weakness of your extraocular muscle, that is visual disturbances, asymmetry of your face or cranial nerve palsies as well. So these are the early manifestations which usually progress over a few days to weeks. By 2 to 4 weeks, usually the maximum insult or the maximum difficulty is reached. Thereafter, it slowly recovers over few weeks to months. If properly managed, early diagnosed, most of the cases are salvaged intact, except very few unfortunate ones.
Dr. Kulkarni, I would also like to ask you one thing, that nowadays when patients are coming to our OPD with loose motions, so should we have a high index of suspicion, and when should we call them for follow-up and monitor? Because now the cases which are happening now are happening during the acute episode. So what should we be on the lookout for?
Basically, the common infections are always here, they will always remain there. Not, though it can theoretically, not every infection can lead to GBS. Not even every definite Campylobacter infection can lead to GBS. 1 in 3,000 infections of Campylobacter has a risk of developing GBS. So the per se risk of developing GBS in an individual patient having diarrheal illness or respiratory infection is very, very, very low. We have to be on lookout for the clinical early symptoms of GBS after 2 weeks, a period during which the immunological disturbances occur and the autoimmune problems start affecting the nervous system. So it doesn't occur immediately. There is a definite interval of few weeks between the initial infection and the development of GBS.
Yeah, so immediately suppose when patients coming gastro or some pain or something, so that you should counsel them. It's not GBS immediately, it's viral infection, myositis, something like that.
Dr. Patil, what are the different types of GBS? Dr. Kulkarni just told about the typical presentation.
So typically what we know is ascending paralysis, which can be sensory motor as well. But there are different varieties of GBS, and that can actually fool you if you don't suspect that. So one is descending, so it is a cervico-pharyngeal and brachial weakness. So typically you have upper limb weakness in that, and then you have Miller-Fisher syndrome where you have ophthalmoplegia, ataxia and areflexia. Also you can have pure sensory, pure autonomic symptoms. So those patients where there is atypical weakness, you should suspect GBS. Also if there are sensory symptoms, you also should have a suspicion for GBS.
So suppose we pick up a child of ascending paralysis, when, at what point should we refer, and who should be the referring body where we should be sending?
Yeah, that is good question. So Typically, if someone starts with a weakness, as Dr. Jhalte suggested, you should think of other differentials as well, because in these outbreak, what we saw, there is viral myositis as well. So probably doing simple blood test of CPK would rule out myositis, and if the CPK is normal, you should start thinking about GBS. But if someone is not able to walk properly or walk 10 meters, there is respiratory insufficiency, there is bulbar insufficiency, you should start thinking of referring the patient to the higher center where the monitoring is required, means intensive care unit is there or facility of intubation and ventilation is available.
And can you briefly tell us how it is managed?
So once GBS is diagnosed, so first of all we'll have to diagnose GBS. So once these patients with this typical symptoms comes to us, first we like to do the investigation to confirm that it is a GBS. So obviously the first clinical pointer is a clinical examination. So nothing trumps a clinical examination, because there has to be areflexia and weakness. After that, in the first week, what you can do is a CSF examination. CSF examination sometimes in the first week can show albuminocytological dissociation. What I mean by albuminocytological dissociation is the cells will be low and proteins will be high. So for example, there will be 10 cells and proteins will be 100. So that is albuminocytological dissociation. The CSF is very important because you need to rule out other viral infection. So most common viral infection at these who can present like this is a enterovirus infection, and enterovirus also can come in outbreak. So it is very important to rule that out. Then after that you can do the nerve conduction studies. So in the nerve conduction studies, one needs to know that in the first week the nerve conduction can be normal, because sometimes the GBS starts proximally and it's more of axonal, and there is a particular test in nerve conduction which is affected in the first week, that is F waves. So this is a test which we look for the proximal nerve conduction. It means the signal goes through nerves to the dorsal root ganglia and then come back. So that is affected first. So when you ask for nerve conduction to diagnose GBS, you ask for whether F waves are recorded or not and how are the F waves. Okay, and then in very early, the other test which we can do if you are suspecting something, we want to rule out a spinal cord as well. So you can do the MRI spine with contrast and look for the dorsal root enhancement. So actually dorsal root get enhanced when you give the contrast, and obviously you look at the spine and rule out the spinal differential diagnosis with that, and these three tests are enough for diagnosis. And moving on to the management, if the GBS is rapidly progressing involving the respiratory muscles and the child has difficulty in walking, we should think of giving treatment. The treatment, there are two modalities which are proven for GBS. One is intravenous immunoglobulin, which is fairly available everywhere in Pune. So what we can give is there are multiple protocols, but I think one which the consensus recommend is 400 milligram per kilogram every 5 days. Okay, so that will come to 2 gram per kilogram. And then the second thing which we can do is plasmapheresis, 200 to 250 ml per kilogram every day on 5 cycles. So now there is a question about whether we should go for IVIG or plasmapheresis, but both are equal in their effectiveness. So one can choose either of it. I go to the Navli hospital also, where sometimes there is a financial issue, so we can go for plasmapheresis in that situation. IVIG is actually convenient to give, so you just give IVIG and requires less monitoring compared to the plasmapheresis. But one added advantage of plasmapheresis is if you give plasmapheresis, and there is no improvement after 2 or 3 weeks, you can think of IVIG, because if you give IVIG first and then think of doing plasmapheresis later, so you'll have to wait for at least 2 to 3 weeks after giving IVIG, because if you do plasmapheresis too early after IVIG, it will wash out your immunoglobulins. So that's how we can treat.
Yes, and one more thing, what is the prognosis? How do the children do? Is it very bleak or most of them recover?
Yeah, before that, I had to add on the monitoring part of it. So how we monitor if we give the medications for plasmapheresis, because as Dr. Kulkarni sir said, that it is actually the GBS, you have progressive phase, then you have plateau phase, and then recovery phase. And the plateau phase can be variable. It can be 2 days or weeks or months. And sometimes patient who land up on a ventilator can be on a ventilator for a month. So we need to monitor these children during this plateau phase, and what we can look for is a muscle strength which is coming up. Then you look for the respiratory efforts, then you look for autonomic symptoms if at all, because they have a lot of fluctuation, BP fluctuation, pain as an autonomic component. So you need to look for them. And then obviously the other nursing care like infection, so they are actually they can get all these respiratory infection or ventilator related infection, and nutrition is very important, and physiotherapy. So these are the things which we need to do during the course of their stay. Coming to the prognosis, as sir rightly said, prognosis is quite good in all these patients, and most of them recover. So if I want to quote statistics, 80% will start walking by 6 months after the illness. Obviously, if there are comorbidities or added complication, then the course can be different, but most of them will do really well.
So now, Dr. Kiran, what precautions should we take and how we tell the parents what precaution they should take to prevent GBS during this scenario?
Yeah, mostly we have seen that this GPS cluster has occurred due to Campylobacter jejuni, which occurs due to unsafe practices like unsafe drinking water or unsafe food eating pattern. We should have a safe drinking water. The water should be boiled at least 20 minutes. Food safety should be taken into consideration. Washing vegetables and fruits before drinking. Cutting of raw meat should be separate. After cutting raw meat on the in the kitchen and in the utensils, they should be washed. They should be disinfected properly. Keeping raw food and cooked food should be separate. And as far as possible, we should avoid eating outside in this clinical scenario.
Okay, so it's not special for GBS. It is general hygiene
general
and food safety that you have to follow it.
Yeah.
Then what are the reporting needs during this situation?
Yeah, if any pediatrician or any clinician found cases, should get a contact number of them. As soon as they found cases like this, having patient having URTI or loose motion type and having these symptoms, weakness symptoms, they should immediately report to the local UHC or PHC hospitals or PMC.
Okay, so thank you, Dr. Kulkarni sir, Dr. Kiran, Dr. Sandeep Patil, and Shushruta. I think most of us have already have a lot of knowledge about GBS. Now it's time to not to be panic, counsel patients properly, allay their fears, and thank you very much.
So don't worry, don't panic, take precautions and be vigilant. That's all. Thank you.
Take safety precautions, as mostly this is due to Campylobacter jejuni. You should take food and water safety precautions.
GBS is treatable in every situation, and most of the patient will recover from GBS. Thank you.
And I thank Dr. Pramod Kulkarni, Dr. Kiran Mahankale and Dr. Sandeep Patil for an elaborate discussion and making us all general pediatricians much aware of the situation. Thank you so much.